Hi guys, this is Alicia with Good Morning Sunshine. So today we had 3 lectures and a lab. Still a 9 to 5 day, so it was kind of sucky. But anyways, we did Pharmokinetics today. What else did we do? We did endocrine 1 and 2. Apparently losing my voice too. And then we ended with dairy cow. We'll see if I can even do this. So I'm going to start with pharmacokinetics, since that was our first lecture of the day. So our objectives to this was to define pharmacokinetics, the principle of drug transport across membranes, the route of administration, and how they affect drug absorption, advantages and disadvantages of each, and formulations, how they affect drug absorption, advantages and disadvantages of each, and pharmacokinetic measurements of absorption and physiological factors affecting absorption. We only got through half of this lecture today, so I'll only go to the last slide that we did, or roughly like where we ended off, because I can't exactly remember. But it's when I stopped taking notes, so that's where I'm going to end off. So basically, pharmacokinetics is what the body does to a drug. So we do this by the acronym ADME, which is absorption, distribution, metabolism, and elimination. And why is this important? It determines drug concentrations in the plasma and the tissues, and it's related to drug efficacy and toxicity. It's also used to determine normal drug dosage regimens. It changes with disease and may change with genetics. Us as vets, or when I get there, have to know the potential changes in pharmacokinetics with disease and prevent treatment failure or drug toxicity. So some general topics or concepts. Drugs must be transported across membranes. This affects all aspects of pharmacokinetics, the ADME. Factors affecting a drug's ability to pass through a membrane include molecular weight, such as protein binding, solubility, ionization status, concentration gradients, and this including blood flow. And then we have some physicochemical properties. So we're going to break each of those things down that I just told you. So we're going to start with molecular weight. Smaller drugs cross membranes more easily, so things less than 400 to 500 Daltons. These are most therapeutic drugs fall in this range. Exceptions being monoclonal antibodies have issues crossing membranes. They're at 20,000 to 50,000 Daltons. So these drugs usually have to be bound to a protein in order to get across the cell membrane. So then we have plasma and protein binding, where drugs enter circulation and bind to a protein. That's what I was just talking about. They need something else in order to get across the cell membrane. So this includes albumin. So weak acids, it's about 67,000 Daltons. So weak drugs bind to this. This is what decreased with inflammation. And then we have our alpha-1 acid glycoproteins, which are weak bases. They're sitting at about 42,000 Daltons, and this is increased with inflammation. So basically the drug plus a protein, its molecular weight is too big. So protein-bound drugs remain in the plasma until they are no longer protein-bound. So the liver at some point will knock off this protein, and then they'll be able to cross the cell membrane. So then we're going to look at solubility next. So lipids versus water. We have lipophilicity, which is how soluble a drug is in fats or oils. Lipo, so meaning fats. Lipophilic drugs cross membranes and distribute widely. They're usually intercellular or abscesses and the central nervous system. And then we have hydrophilicity, which is how soluble a drug is in water. So hydro meaning water. Hydrophilic drugs are confined to the plasma and the plasma, sorry. And then we have ionization. unionized nonpolar drugs distribute more widely. They becomes more lipophilic. It's dependent on pH and pKa. pKa, if you remember, is the pH of which 50% is ionized and 50% is unionized. So of the drug, like unionized and weak acids unionized in acidic environments such as the stomach and urine, whereas weak bases are unionized in basic environments such as saliva. And this depends on the species. So then we're going to get into concentration gradient. At a higher concentration, more drugs for diffusion. It can alter with dose and route. Assumes that there is no blood flow to the area to deliver the drug, and this is affected by disease. So then we have mechanics of drug transport. We have something known as passive diffusion, which I've talked about before. This requires no external energy. At equilibrium, there's no net transfer is 0. It is non-selective and is non-saturable. It is the first order in linear kinetics. The rate of diffusion is proportional to the CH minus CI. So from this basically meaning from high concentration to low concentration. So this being the concentration gradient. It's probably the single most important factor for passive diffusion is the concentration gradient, which is most easily manipulated by increasing the drug dose. And then we have small unionized water-soluble drug molecules. So an example, this is being an example of a passive diffusion. They go through aqueous pores. They don't go through membranes very well, but at high molecular weight drugs rarely use passive diffusion. High ionized drugs cannot get through, and then moderately ionized can get through sometimes, but they get through very slowly. So then we have lipid-soluble drug molecules, which go through the pores. They rapidly go through the cell membrane, so that makes them different from the small unionized water-soluble drug molecules. And then all the other stuff that I told you before are the same. Then if you remember, fixed law of diffusion, we have D times SA times PC times the concentration gradient. So D being the diffusion coefficient, SA being the area, PC being the partition coefficient, and D being thickness. So then we have carrier mediated passage, which drugs lacking sufficient lipid solubility for passive diffusion. So drugs that don't go through passive diffusion well or cannot get through at all will use a carrier mediated. The carrier may be specific for a drug. It has competition for the carrier. Transport mechanisms can be saturated, giving higher concentration of drug. Doesn't mean you're going to get high concentration on the other side of the membrane. Typically for drugs that mimic endogenous substances, at saturation, the amount of drug transported remains constant no matter what the gradient, which is different than diffusion when the amount transported is dependent on a concentration gradient. So examples of carriers are the PGP efflux pumps, which are important for anti-cancer drugs and cancer resistance. So again, getting into drug transport, we have the carrier mediated facilitated diffusion, which is a special transport proteins in the plasma membrane. It goes with the concentration gradient and does not require energy. And then we have the active transport, which is carrier mediated as well, but it goes against the concentration gradient and it requires energy, like ATP. So now back to pharmacokinetics. We're going to start with absorption. Drug must be absorbed across membranes into the systemic circulation plasma to reach its site of action. The route of administration plays a very important role. The vet gets to choose how we give, so IV, IM, sub-Q to some extent. Routes of administration, routes are chosen based on physical chemical properties of the drug, formulations available, therapeutic indication, pathophysiology of the disease, and target species. So we have all different routes, but the top 4 being intravenous, intramuscular, subcutaneous, and oral. However, we have buccal, mucocal, we have transdermal, epidural, topical, rectal, intradermal, intraperitoneal, and subconjunctival. There's a lot more than that too, but we're going to stick with the top 4, and I'm going to explain those to you. So we have intravenous, when the drug is injected directly into the bloodstream. It skips the absorption phase and goes straight in. Advantages of this are it's at highest concentrations. It has highest efficacy, but some of its disadvantage, or it's the highest risk of toxicity. It is technically the most difficult to give. It has a risk of carotid injection, because the carotid artery is right next to the jugular vein. So we could accidentally give it into the carotid artery, which would shoot up the drug at high concentration straight to the brain. So that'd be very bad. And then we have intramuscular, where muscles are highly vascular. Absorption from the IM route is often high. Its advantages are that it's easy to perform. Large animals with large muscle masses, neonates and small animals don't, however. Disadvantages are possibly of administering drug into a vessel. It could be painful, and drugs may cause muscle necrosis and abscesses and infection. So then we have sub-Q, which is the absorption's moderate to high, more variable than the IM route. Its advantages is easy to perform and less painful than IM most of the time. Disadvantages being during dehydration and or shock, the skin receives less blood flow. So moderate to severe dehydration or shock can decrease drug absorption from the subcutaneous injection. So factors affecting these are lipid-soluble drugs, more likely to form depot in the IM and subcutaneous space. Lipid-soluble drugs often absorb slower. Water-soluble drugs are often absorbed faster. Doesn't necessarily mean less will be absorbed though. Sustained release formulations release drug over a long period of time. And drug vehicle affects solubility and absorption. So highest, we have aqueous solution, then we have aqueous suspensions, and then we have oil-based solution, and then oil-based suspensions, and lastly, we have solid dose forms. So getting into some terminology now, intravascular versus extravascular. IV is directly injected into the vein. We assume 100% absorption, whereas EV, which is extravascular, which is every other route we use, like IM, sub-Q. And then some drug will remain at the site of administration. Assume less than 100% absorption. And then we have enteral versus parenteral. Enteral means administration via the GI tract, whereas parenteral is everything else. That's the IV, the IM, the sub-Q. And then lastly, we have oral. Absorption ranges from 0 to 100%. It is the most variable. It is the slowest. It has species differences. They have monogastrics versus ruminants. It affects of feeding and diet. Carnivore versus omnivore versus herbivore, fat content. Oral is not preferred route for ER situations. Oral has to do with feeding, human drug instructions. So we're going to compare oral human medications versus dog. So like when human drugs they take with a glass of water, this means that the drug is a water-soluble drug, and the drug must dissolve before being absorbed. When it says taken with a meal, it's usually a lipid-soluble drug, so it's based on solubility. It is difficult to apply to veterinary species. The advantages of oral is that it's cheap and easy in most animals. Disadvantages is how much the drug loss, administration, vomit reflux, degradation by stomach acid and rumen colon microbes, and its effect on the GI flora. So reasons for poor oral bioavailability. Drug is not delivered from its formulation to absorption site in the gastrointestinal tract, water soluble enough to go into solution, lipid soluble enough to be absorbed across the GI membrane. Drug formulations may have solubility enhancers to improve absorptions. Drug must go into a solution before it can be absorbed. It may be a rate-limiting step for lipid-soluble drugs. I'm pretty sure we stopped around here. So I'm going to stop around here, and then I'll finish the rest when we have the other lecture. So then we're going to get into endocrine. So we took actually 2 lectures. He put it into 1, but it didn't take that long. So the endocrine system is complicated, it's intricate, and elegant. He kind of, his lectures are something. And all his slideshows are lowercase, which bugs me. But anyways, moving on. Components of the endocrine are hormones, organs, metabolites, and metabolic products. Any of these 3 can be taken as primary organizing principle, and each method emphasizes certain details. So who is this? He asked us who this was. I had no idea. But anyways, it's Sequoia. Apparently he's a Cherokee scholar in the early 1800s. The written word is able to throw words at a distance, I guess. He died of actually a respiratory illness while trying to reunify the Cherokee bands that had fled to Mexico, with those remaining in the Indian Territory in Oklahoma. But he compared this to endocrine control, because it's words thrown at a distance. I don't know. It didn't make much sense to me, but I'm going to tell you that. But anyways, 4 major types of intercellular communication are hormone, which are produced in one area. It is transported by blood. It affects cells in another area, and it acts on low concentration. And then we have paracrine, which are produced in one cell. They are transported by in the extracellular fluid to adjacent cells and affects those. Some overlap with hormones like prostaglandins, cytokines, and somatomedins. And then we have neurotransmitters, but they couldn't be considered paracrine. And then we have autocrine, which are produced by and affect the same cell. So hormones have 2 classes. You have the proteins and other polypeptides, and then you have the steroids. This division is key to understanding the synthesis, the secretion, the transport, and the receptor location and function. So we're going to start with protein synthesis. It is made in ribosomes as a pre-pro hormone. The pre part attaches to the rough endoplasmic reticulum. It's then removed, leaving the pro hormone, which is put into the cytoplasmic vesicles, which coalesce, which means merge together. So little ones to make a big one, basically in layman terms. And they lose the pro to leave just the hormone, which is stored in a coalesced granules until released by a stimulus. Secretion is mediated by ATP and calcium, so it takes energy. Pre and pro help to guide the protein along its path, and it's essential even if they're temporary. And then we have steroid synthesis, which is not stored. So protein synthesis means stored, whereas steroid synthesis is not stored. It's formed as needed. Cholesterol is stored, but everything else not stored. It's mostly made from cholesterol from the liver. It can also be built anew from acetate and is formed in mitochondria and other cell compartments. So then we got into transport. So proteins are hydrophilic. They love water and they simply dissolve and float along, whereas steroids are lipophilic. They don't dissolve. They're associated with binding proteins. Thyroid hormones are like steroids, but they're not steroids. And then we have specific binding proteins. They are unique to individual steroids. They have high affinity and specificity. And then we have non-specific binding, such as 2-albumin. Blood protein, it's a blood protein made in the liver, which is abundant and therefore transports a lot. Then we have bound and unbound, so specific and unspecific binding, which exist in the equilibrium, with unbound being about 1%. And then assays detect both of these. And then we have protein hormone receptors, which are external. Protein hormone receptors are on the cell surface. They trigger a cascade of activation of enzymes and eventually signal to the nucleus. Steroid hormone thyroid receptors are internal, so in the cytosol or the nucleus, they have a shorter pathway to upregulate the nucleus. And then we have degradation, which are protein hormones are cleaved by peptidases, and then steroid hormones are reduced, conjugated with sulfates or glucuronides. They are then water soluble and it can be excreted in urine. So what do? They regulate metabolism, such as mineral balance, water balance, energy protection and maintenance, and reproductive control. Most hormones target only one of these functions. And then we got into endocrine 2 notes, so another lecture. So then we got into feedback loops. So feedback is one of the most important concepts in endocrine physiology. These are loops with no beginning and no end. And understanding these is essential to pinpointing where things have gone wrong in a disease. So feedback is the general idea is that a concentration of something is sensed and then leads to either upregulation or downregulation of an endocrine product. Most feedback is negative throughout the body, so which means it's adequate or above adequate, in the sense that an adequate concentration turns off some stimulatory sequence. Negative feedback loops keeps hormonal levels from increasing to abnormal levels. So feedback loops, some are short and involve only the hormone and the metabolite. Some are long and involve multiple hormones, especially the pituitary trophic hormones. And then long loops usually have short loop components as well. Redundancies helps build in finer control. So to figure out what the problem is, we measure the hormone, we measure the metabolite, and measure any stimulatory hormone. This will therefore pinpoint the failure. So then we got into lots of information like different drugs, what they do, and what kind of feedback they do, and what it causes. We have to know a few of them. We have to know oxytocin, vasopressin, ACTH, growth hormone, and a lot of other ones that I'm not going to go through. But what's the point? So it's a quick reference. So all those tables that I was just talking about and all the drugs. It is an appreciation of feedback interrelationships. It is a link of the hormone to action or metabolite. So yeah, he gave us fair questions so you can ask on the exam, and then the importance. Some are essential, some are trivial, but fascinating. The essential ones, of course, have an asterisk. So he gave us again the drugs that I was talking about, the ones we have to know in those big charts. But it's still a long list. So that's the end of endocrine lecture until he talks again. And then the last lecture we did dairy. So production systems in dairy. So the objectives were the industry, the animal, and the farm. So modern dairy farms are conventional or grazing. So conventional being they're in confinement, they have partial or total confinement, they have high input costs, they have high production. Grazing, cattle eat grass as a large part of their diet, they have lower input costs, and they have lower production. So then we got into conventional versus organic, so conventional milk production regulated by pasteurized milk ordinance, so by the PMO. All loads of milk are tested for antibiotics below levels that FDA deems safe. And milk tested monthly for somatic cells and bacteria. Organic, however, have a UHT, an ultra high temp pasteurization. It costs more. Milk production, again, is regulated by pasteurized milk ordinance, which is the PMO. Just like conventional, all loads of milk tested for antibiotics, and milk tested monthly for somatic cells and bacteria. So this is where they're the same. Differences between conventional and organic. Organic has USDA regulation for what cows can be given. Milk processors may have stricter guidelines and illegal to withhold treatment to keep organic status. So then we got into the life cycle of dairy cow. This includes the heifer. They're usually born in a dry, clean pen. We removed their baby ASAP. They dip nabble with 7% iodine ASAP, colostrum ASAP, quality, quantity, timing, number of feedings. So then we got into the life and production cycle. So at birth, they come out weighing 80 to 100 pounds for a Holstein, and 40 to 60 pounds being a Jersey as a heifer or bull calf. Historically calved on calving pastures, now more maternity barns or stalls. In the U.S., calving typically occurs year-round on farms, but seasonal calving emphasis may occur for milk grazing dairies. They're removed from the cow usually within hours, certainly within days. They're hand-raised and perhaps in a calf hutch. Bull calves may or may not stay on the farm at this point. Decreasing numbers go into a veal industry. Most will be raised for beef, but often are sold early on. Most producers think of the bull calves as byproduct rather than as a major part of their operation. The baby calf diet is waste milk, pasteurized waste milk, and milk replacer. Nursing calves, mostly heifers, are fed whole milk, often from treated cows or commercially prepared milk replacers. Within days, they are offered a calf starter grain ration that is very palpable and contains high amounts of protein. Calves are typically weaned at 8 weeks of age. This is not weaning in the same sense of the word as it's used in many species. These calves are still pre-ruminants and are so not ready to survive on the roughage-only diets. They will be fed a calf grower concentrates with about 16% protein at the rate of about 2% of their body weight for several more weeks. Development into a ruminant 3 to 4 months life. So we're at 3 to 4 months now. Developing heifers gradually move to a ration with less concentrate, typically a 0.5% to 1% concentrate, but may have developmental periods where they eat only forages. And then we get into the puberty age. Generally gain about 1.7.5 pounds per day to reach a target breeding weight by 15 months of age. This weight is about 2/3 of mature weight, or 800 to 900 pounds for Holsteins and 550 to 650 pounds for Jerseys. The dairy heifer development on pastures or in barns. And then breeding, AI only, AI for 1 to 3 services, then bull. So AI meaning artificial insemination in heifers, then mature cows because of less convenience in handling. Alternative is to breed heifers by natural services. Growth should continue about 1.7 pounds per day. And then we got into calving. Heifers usually calve or freshen and begin lactation at 24 months of age. The first lactation production, and then we have the first calf heifer production, and then the heifer production. Will originally give about 3/4 of amount of milk mature cows are giving, but will get closer to cow production levels as their lactation progresses. So milking usually occurs 2 to 3 times a day. Cows are milked in a station barn, or they are milked where they live, or cows are milked in a parlor in a special area only for milking cows. So we have all different kinds here, so you don't have to just listen to me talk. So we have the herringbone parlor here. We have a parallel parlor. We have milking there. Then we have a rotary parlor. And then we have robotic milkers too. And then we got into transition, which is a switch from dry cow life to lactating cow life. It is dramatic metabolically, socially, and environmentally. It's called transition and must be managed carefully, or many diseases and losses in production result. Lactating cow nutrition. Cows eat a combination of roughages and concentrates. On a dry matter basis, at least 40% of the ration should be forage. Many of the forages for dairy cows are harvested by chopping and ensiling for decreased harvest risk and ease of mechanical handling. Lactation we got into, which is high producing Holstein cow. The peak lactation is at 60 days. Milk production begins at a monetary high level after calving, increases for several weeks to a peak, which again is between 40 to 100 days, but we're going to say 60 days. Then decreases at the lactation proceeds 8 to 10% a month. Cows must freshen again to resume the high levels of production. So nutrition, think about it as a 50-50-50. You have 50 pounds of dry matter, 50% of moisture, and about 50% grain and 50% forage. Nutrition forages, most dairies grow most of their forages on the farm. You have corn silage, which is the entire corn and ear chopped up and stored anaerobically so that it ferments. And then we have haylage, which is alfalfa, grasses, or small grains such as rye, barley, and wheat that is chopped up and fermented. And then we have lactating cow housing. Cows are housed in concrete lots with 4x8 beds called free stalls. They may or may not have access to outside lots called exercise lots. There's dry lots with shade cloth, or some loose housing uses a bedded called a bedded pack. And then on pasture with only a concrete lot to hold cows for milking and feeding. And then they have a station stall for living and milking. So this is the first one. It's a freestall barn. It keeps the udder away from poop. And then we have the dry lot here. And then we have the bedded pack. And then we have the station here. So dry cows, the mammary gland and digestive system need a rest for the next production to be optimal. The milk removal stops 60 days before the next parturition to give the cow a dry period. Cows should be housed separate from lactating herd and fed a mostly roughage ration. When do I dry off a cow? When she is either 40 to 60 days from calving, when our milk production drops below the break-even point at about 30 pounds. Dry cow lot early if pregnant, sold for coal if open. Far off dry cows, it is the end of last lactation, R&R for the rumen and udder. Close up dry cows, beginning of the next lactation, udder development, fetus development, preparation of the rumen for high energy diet. And that was it. That was my lectures for today, but then we had lab, which kind of killed my brain. We're doing drugs and math on drugs, and it was just a lot. So, but it's been a long day. I have a long ass day tomorrow. I'm 8 a.m. to 9 p.m. I think. So, not too psyched about that, but I guess we'll make it through. I hope you guys all had a good Monday, and hopefully lectures weren't so boring today to listen to. But I love you guys, and I thank you guys for watching.